did you record the lectures on the very first day? Like, is my clinical lecture 2 recorded? Okay, so that's available with you, huh? Clinical lecture 2. The reason I am saying this because I received an email asking me like which parts of the lecture will be in the midterm and which will not be in the midterm, things like that, and specific slides. And so I had explained this during the lecture on most of the slides. Like if there was something which was felt like this more of a pulmonary thing, I said like this you will do in the pulmonary part, but this part is more relevant to your cardiovascular part, and this can be asked. Like, so please first listen to the lecture. If you haven't attended the lecture, first listen to the lecture, and then if it's not clear, then ask. Otherwise, like I cannot transcribe the whole lecture again. So I cannot go over each and every slide and say, okay, this is in the midterm, this is not in the midterm. So to give you a couple of examples, and I knew that these type of emails come every year, and that's why I tried to explain it during the lecture clearly. Like for example, breathlessness, dyspnea. This happens both in pulmonary problems and cardiac problems. So obviously you will have questions where there will be breathlessness. Now, but like the focus would be on the cardiac causes, like heart failure. This is one of the causes. There are valuable problems which you will do hopefully next week. And so there are many other problems which will lead to breathlessness. MI leading to pump failure, leading to heart, acute breathlessness. So in that situation, yes. And then the question was like whether the palpitations or crackles. Now that's part of the respiratory, but this is part of the cardiovascular examination as well. So crackles can happen due to many diseases which are pulmonary. Obviously, we will not give you a case of a pulmonary disease, but we can give you a case of heart failure and where the patient will have bibasal crackles. And this I clarified during the lecture on those slides. Okay, like the crackles, when I was talking about crackles, I said like this can happen with pulmonary edema. So someone who has pulmonary edema, and you will get, and I hope you get a case on pulmonary edema as well. So that patient will have crackles. So that's why the signs and symptoms cannot be separated. Obviously, like I will not give you a case of, or somebody will not give you a case of interstitial lung disease, which you will do after the midterm, or a case of asthma. But suppose if somebody gives you a case of pulmonary edema, a clear case of pulmonary edema which has bibasal crackles, so in MCQ obviously you need to put some wrong choices. As a wrong choice, there can be asthma, there can be pneumothorax, and obviously, but so you should be able to identify, okay, this is pulmonary edema or this is PE. So someone who has chest pain and like breathlessness, and then there will be other features, risk factors. So you would know this is because of PE rather than because of pneumothorax. Okay. So it will be very obvious case in for any question, like we usually try to make it very obvious. And obviously, as wrong options, there can be many other things which you may not have, like pneumothorax. I'm just giving you again examples. Or asthma, which you will do in detail later on, but you should be able to identify, okay, this is pulmonary edema. So then you don't need to think about other wrong choices. Is that clear? So if somebody is not clear, you can listen to the lecture again, and then let me know if there's any problem. So you guys are recording again? I thought it was the boys who were recording now.
We are.
Sorry?
We are. We will do.
Now girls? So you switch like every week or what? Like, does it take so much effort that like you have to divide it? Okay, so let's start with palpitations. And the reason I sent, because I don't want to go over those boring slides again. Some of them we already covered during our clinical lecture 2 and 3. Probably we did palpitations during clinical lecture 2 or 3. I think in the first one, huh? So we covered most of the descriptive material during that session, and there's some additional material. So I sent you like all of them together as a reading material. So objectives would be the similar as we did in chest pain. So our objective is to develop an approach to a patient who presents with palpitations. And obviously you will take relevant history and gather the data based on history, and you will do the relevant examination, and then you will formulate a presumptive differential diagnosis, and then you will do relevant investigations. So you should know which are the relevant investigations to confirm your diagnosis, and you should not miss the life-threatening causes. That is very important. Okay. So let's start with the case. So a 32-year-old female accompanied by her father presents to the emergency department complaining of rapid fluttering in the chest for 1 hour.
Palpitation?
Yeah, so what is rapid fluttering?
Palpitation.
So this is a palpitation. This is one of the descriptions for palpitations. Like they can describe in different ways. So one of the way is saying like we are having rapid fluttering. So they feel something is fluttering in the chest. Okay. Anything else in this story? Like 1 hour duration. Okay. So sometimes it goes away in minutes, a second. So this is like sometimes it can be like 1 or 2 minutes. This time it's going on for 1 hour. So it's quite significant. And anything else in this sentence? Sorry? Age, huh? So she's 32-year-old, so not very old. So probably she doesn't have. She's less likely to have like coronary artery disease and ischemia and heart failure, that kind of things. But she may have some cardiomyopathies which can happen at a younger age, or she may have some other congenital or inheritable channelopathies which can lead to arrhythmias. Or there may be some other reasons. So, but she's relatively young, 32-year-old. Anything else?
That she's accompanied by her father.
Okay.
This could either go two ways. It's either that she is severely ill and she can't go on her own,
Okay.
or it's just that more traditional
Okay.
thing.
Yeah. So here in this culture, probably it may be like normal.
Maybe psychological.
Yeah, but like if you are in a different culture, then at this age, they will come alone. Or if they are sick, then the person who would be bringing them would be usually their partner. So here she's with father. So that indicates that probably she's living with her father.
She's not married.
Okay. So this could be one of the indications here, which we'll think about that in a while. And is that important?
What is?
Like living with father?
Yes.
How?
Maybe she's anxiety driven, so she doesn't want to live alone.
Okay.
Dependency is.
She could be, she's innocent.
She? She could be? Like she could be single, huh? Like it's very normal. Like someone married who's visiting her parents can come with father. This is very normal. But like the other way of looking at it, she may be like single, living with the parents, so dependent financially as well. So there can be like other messages here. So you know the slide. So what is palpitation? So again, this is an awareness of the heart beating. Usually we are not aware. But when we become aware, and then when we become aware, it's quite unpleasant. When we feel our heart beating, and this feeling can be described differently. Like it can be like pounding, jumping, racing, irregularity of the heartbeat, or they can feel a flip-flopping or fluttering in the chest, or they can feel pounding in the neck as well. So usually they say my heart is racing. This is typical description. So when we become aware of our heartbeat, so it feels like my heart is racing, and that induces anxiety as well. So anxiety can induce palpitations because of tachycardia, and this awareness of palpitations can induce anxiety. So underlying mechanisms. So one is this autonomic imbalance. So if sympathetic, if for any reason, if there's like more sympathetic stimulation, whether it's like because of some disease which is causing autonomic dysregulation inherently, or if there is any exogenous things like drugs caffeine, things like that, or like stress. So sympathetic overdrive, imbalance in sympathetic and parasympathetic system, vagal irritation, drugs. So all those things can lead to. So this can be one of the mechanisms. Sympathetic overdrive is one of the mechanisms of palpitations. The other could be they may have a structural problem in the heart and they may have some arrhythmias. So they may have an arrhythmic disease which is causing arrhythmia. Or there may be hyperdynamic circulation which can also lead to palpitations. We'll talk about those things. So before we collect more data, we should know what are different etiologies of palpitations. So how do you categorize different etiologies? Like, do you remember those categories which we did last time?
Cardiac, non-cardiac.
Okay, so cardiac causes, non-cardiac causes.
Non-cardiac is
Good. Okay. Okay, so metabolic causes like hypoglycemia. Okay. So we have cardiac arrhythmias, then we have structural heart diseases, then we have psychiatric or psychosomatic problems, systemic causes which will include all metabolic things, and then we have medical or recreational drugs. So, and obviously this has to be interpreted in light of how the patients are presenting and in which circumstances do they develop these palpitations. So as we said, they can be described in different ways, and the common ways, like they can describe it as flip-flopping, a rapid fluttering, a pounding in the neck, and this can give us a clue to the etiology as well. And also, during history, we need to find out in which circumstances patients are developing these palpitations. So we need to take more history, and that can also give you a clue, like are they associated with anxiety or panic attacks? Are they associated with periods of catecholamine excess, like during exercise or during lectures? Yeah, like while coming here, I might have felt some palpitations. Are they associated with any particular position? Sometimes somebody might develop palpitations while lying, while they're lying in their bed. Sometimes when they get up from sitting position, they might feel palpitation. So again, this gives you a clue towards etiology. So they may have some autonomic problems while if they're getting palpitations when they get up from sitting position. And also you want to know is there any syncope or near syncope associated with palpitations? That tells you there is serious arrhythmia. Okay, so let's talk about the case. So you know this 32-year-old female and comes with rapid fluttering in the chest for 1 hour, and she has experienced similar episodes in the last 2 months. Each episode was spontaneous in onset and resolution. So this is a chronic phenomenon. Like relatively, it's not like first presentation. So she has been having this thing for 2 months, and the other thing is, this is very important: spontaneous in onset and resolution. There may be a reason, but like it's not like when you are under stress or when you start running. So it doesn't like the heart rate doesn't go up suddenly and doesn't come down suddenly. Like if when you stop, so it goes up gradually, it comes down gradually. But there are types of arrhythmias which can be spontaneous in onset and spontaneous in resolution. So that indicates some types of arrhythmic problem.
Doctor, can you give an example of something that is?
Yes, I will give you an example. Like as we go along, sorry.
The differentials that we should have in mind whenever we see this statement.
Yes, because I don't want to reveal the diagnosis at the moment. But like what I'm trying to say, so this may not be just simple tachycardia. It may be due to some arrhythmic problem. When like all of a sudden it comes and then all of a sudden it goes away. Okay. So suppose what else you want to know, like the most important associated symptoms that you want to know, which can be like life-threatening if it present. Sorry. So yes, so you want to know syncope, presyncope, dizziness, chest pain, yes, yes, dizziness. So these are the things that you want to know, that if she's having those things, then that indicates problems with the cardiac output and some serious issues. Huh? So obviously you want to take detailed history, and you have done the components of history previously. So we don't need to go into that detail, but like they need to give a detailed description of their palpitation, and it's helpful if you can ask them to tap out the rhythm. So that will give you an indication: is it a rapid or slow? Is it regular or irregular? So at least if they can tell you that, that also gives you some clues. What else you want to ask them? Like in this case, what else you want to know? Sorry, medications. Okay, so you want to know which if she's on any medications.
Feels anything else than palpitation.
Okay.
We asked about associated symptoms.
Sorry.
We asked about associated symptoms in the previous slide.
Yes.
So now, what other questions that?
Yeah. What else you want to know?
If she had history of infection recently.
Okay.
Timing of the timing.
Timing. Okay. So is it coming in any specific situation? Okay. So any insignificant cardiac history in the family. Also, if she has also previous cardiac history. Lifestyle. What in lifestyle? Emotional stress. Okay.
Sedentary lifestyle.
Sedentary lifestyle. Are more stressful and more active. Caffeine. Okay. Good. Sorry. Chronic illness. Allergies. Allergies. Why? Why you want to know about allergies? Allergies leading to hypertension.
Anaphylaxis.
Hypotension.
Allergies, she would use medications, so that would help.
So anti-allergic medication.
Yeah.
They lead to palpitation.
Yeah, if she's taking steroids or nasal decongestants, yeah, there's a
If she's taking decongestants, yes. But for allergies, we give anti-allergic.
So
Antihistamines. Antihistamines should really be palpitation.
No, it's a basic diet.
Anything else? Why autoimmune disease? Hyperthyroidism, very good. So you want to know about hyperthyroidism. So any problem which can lead to hyperdynamic circulation, including hyperthyroidism, which is known to be associated with palpitation. Good. Recent surgery. Why? Of surgery. Sorry? Renal disease. Why renal disease? Okay, it can lead to electrolyte imbalance, that can lead to arrhythmia and can present as palpitation. Also, disease can lead to one more thing, uremia and pericarditis. Not related to palpitation, but like anything else? Heart failure, yes, but like in this age group, again, is less likely. She doesn't have any. So you want to know if there's a breathlessness and things like that?
If she had a previous history of heart surgery, then maybe there is damage to the conducting system.
Previous history of heart surgery. Are any cardiac problems? Huh?
Yeah.
Okay, so we find out that she does not have any chest pain or syncope or presyncope. So that's good. And this we knew already. Huh? We also found out that in the last 1 week, she developed symptoms of common cold, for which she is taking some over-the-counter medications. So most likely she is taking. Sorry.
Antihistamine?
Can you be a little bit louder? So decongestant, not just nasal, not topical, but like orally, like the most flu medication, cold medications, they have this time it is like persistent for 1 hour. So probably she has some previous risk factors, but now it can get worse. So it's been going on for 2 hours, so 2 months, but previously it would go away as well spontaneously, but this time it's not going away. And okay, this is one risk factor. The other thing is she has increased her intake of coffee from occasional to 3 cups a day in the last 6 months. Okay, so she has increased her coffee, and she also is taking recently. She started energy drinks as well, which have too much caffeine. One energy drink has like around 3-4 cups of coffee. That much caffeine. So like if you, this is typical scenario on the exam morning. You don't sleep well, you're stressed, and you take a lot of caffeine, energy drinks, and when you are going for the exam, just before entering the examination hall, so palpitation. So this happens. So always the palpitations don't, because we will go over many structural anomalies. So this doesn't mean that all palpitations are like diseases. They can be just because of sympathetic overdrive, leading to tachycardia and leading to the awareness of heart beating. Okay. But obviously, when it comes to patients, so you need to rule out life-threatening problems and arrhythmic problems. He denies any use of drugs of abuse, so they can also cause palpitations. She is single, unemployed, so she's financially dependent, lives with her parents, so these are all stressors, and she is taking care of her terminally ill mother. So is that a stressful situation?
Yes.
Taking care of terminal relatives, like relatives who are terminally ill, is a very stressful job. It's not just the grief that a relative has an illness, but taking care of them is a very demanding and ungrateful job, because the person is usually elderly. In our culture, in Western culture, they are in the old homes. But in our culture, when you are taking care of them, they are very old, they are demented, they don't probably know what is going on. So, and they are very irritable. So they would most likely be shouting at you, and you are taking care of them, like or doing all sorts of things for them. So it's very stressful. The reason I am emphasizing, because this is a common situation in the Eastern culture. So people who are taking care of them also need a break. So probably as another family member, as a grandchild, we can give some break to our parents who are taking care of our grandparents. Because the caretakers, they need, sometimes they need counseling as well, and they definitely need a break. It's very stressful. Okay, so we know there are lots of stressor in her life, and she's taking a lot of caffeine, and she's now taking some medication which may be symptomatic. So all these are a good recipe for tachycardia and palpitations. So this may be, as we said, like this can be any of these causes, but she may have some other illness like hyperthyroidism. She may have some other problem. So we need to do some examination, and we need to do some investigation. So do we need to go into these details? So cardiac arrhythmias. So there are different types of cardiac arrhythmias, like you have, which can present as palpitations, like extrasystoles, premature contractions, whether atrial or ventricular. Usually it is tachycardias which present with palpitations. Bradycardias is not that common that they present with palpitations. They present more with syncope, presyncope, fatigue, that kind of thing. But sometimes they can have palpitations, but it's usually the tachyarrhythmias which have more. So premature contractions, whether ventricular, supraventricular, and then the tachycardias, sometimes bradyarrhythmias, and sometimes if they have some device placed in, and if that's malfunctioning, that can also give this feeling of palpitation. Then there are structural heart diseases, probably I think most common would be mitral valve prolapse. And then we have psychiatric or psychosomatic disorders, anxiety, generalized anxiety disorder. And you have done psychiatric part in your neuro. So you should be aware what is anxiety, what is generalized anxiety disorder. Then there's a panic attack or panic disorder. So if one is episode, then it's a panic attack, or if there's history, then panic disorder. Then there are phobias, depression, somatization disorders. So they can also be a one cause. But again, you should not label somebody with these things before ruling out other like true arrhythmic causes. Okay, that is important. Especially in case of females, people have a tendency of like labeling them with anxiety and these things. And when they come in with palpitations, and if they don't find anything obvious, because usually when they present to you, their rhythm is normal. So you do the examination, you do the ECG, you don't find anything, and then they say, okay, probably because of anxiety. So we have to be careful. And then we have systemic problems like hyperthyroidism or thyrotoxicosis, which is very important. And what would you do to rule that out? So one thing is on history, what would you see in hyperthyroidism? Sorry? Heat intolerance. Weight loss. Sorry? There may be some diarrhea as well.
Amenorrhea, in the case because she's a baby.
Amenorrhea, sometimes the menorrhagia as well. So menstrual irregularities, and but the prominent things are weight loss, unintentional weight loss, with increased appetite, and
Decrease or increase?
appetite is increased. It's just because of the metabolic rate they are losing weight. They may have diarrhea as well. So diarrhea, weight loss, unintentional weight loss with good appetite, and then they have tachycardia, they have tremors, and then you can see something on the examination. You might see permanent thyroid, you might see goiter, which can happen with hypothyroidism. So and you can see other like eye findings, some other findings. Yeah. So and then you have like other conditions where there's hyperdynamic circulation, like fever, anemia, pregnancy. So obviously you need to take history and do the examination. So you, in case of female, you want to know the last menstrual period, when was it, and if it's and you want to rule out pregnancy, you want to check for anemia, the fever, and pneumonia is known to cause palpitations. So if there's fever and if there's breathing difficulty, so you want to look for anemia or pneumonia as well. Hypoglycemia because of sympathetic overdrive will lead to palpitations. Electrolyte imbalance can lead to abnormal rhythms and palpitations. And Peyer's disease again leads to hyperdynamic circulation, that's what leads to palpitations. Hypovolemia again because of hypotension and leading to tachycardia can lead to palpitations. And exercise, of course. And some people have it during exercise, some people have it at the end when they stop. Like so when the sympathetic output is going down and when there's a vagal inflow, and at that time they might develop palpitations. So again it can vary. Sometimes like while you're running, and other times when you stop, and at that time you will feel this pounding in the neck, and sometimes it can happen normally as well. Because of tachycardia, sometimes atrial ventricles can contract simultaneously, so it can give pounding in the neck. And then we have drugs. So like anything which is sympathomimetic can give this feeling of palpitations, like beta agonists in pump inhalers, thyroxine if someone is on thyroxine, vasodilators, anticholinergics, and then if someone is on beta blockers and if they stop taking beta blockers, so that can again lead to rebound tachycardia and palpitations. And then you have like alcohol, cocaine, heroin, amphetamines, caffeine, nicotine, so smoking as well, cannabis, synthetic drugs. So there are different things which can lead to. So these all things are sympathomimetic, and that's why they lead to palpitations. This is just in one table. So you have like cardiac causes, psychiatric medications, habits, metabolic disorders like hypoglycemia, thyrotoxicosis, and high output states like anemia, pregnancy, fever, Paget's disease, stress. Okay, so coming back to examinations, she's restless, well oriented in time, place, and person. Heart rate is 160. What time is it?
10:43.
Okay. So she's tachycardic, but it's regular. So this is important here, huh? If it is irregular, then again you will think of irregular rhythms, okay? And she's not hypotensive, so vitally she's stable, like she's not hypotensive. So that's again very important. She's afebrile. So you do the rest of the examination. This is what we find out. So we have 32-year-old female with fluttering in the chest for 2 hours, 2 months history of this type of problems. Coffee, energy drinks, common cold, over-the-counter medication, unemployed. So now what do you think at this stage? Hmm? So stress and that's compounded by the caffeine as well as and over-the-counter medications. So which investigations would you order?
ECG.
Good, ECG. What else? CBC, okay. Thyroid function test, good. And electrolytes, very good. So ECG, complete blood count, electrolytes, thyroid function test, echocardiography to look at the structural, if there's any structural abnormality, chest X-ray to see if there's any obvious abnormality like cardiomegaly or pneumonia and things like that. And then if she has a history of drug abuse, then you can do some toxic screening. So this is ECG. So she's tachycardic right now, so ECG is helpful here. Otherwise, if she's normal, then it won't help.
Sinus tachycardia.
Is it? Can you see P waves? So then it's not sinus, huh? So there is tachycardia, but it's not sinus, okay? Now number 2, because you have done the tachyarrhythmias and bradyarrhythmias. Is the QRS complex, does it look coming from ventricles? Is it more than 120 milliseconds? No, huh? So it's narrow complex. So this is ventricular, supraventricular. So this is supraventricular tachycardia, and it's coming in paroxysms, huh? So paroxysmal supraventricular tachycardia, because it is coming like on its own suddenly and then it goes away. It comes in paroxysms based on history. Here you have supraventricular tachycardia, SVT. This is not ventricular, this is tachycardia, and this is supraventricular tachycardia. This is not sinus tachycardia. Okay? So we did CBC, which is normal, so she's not anemic, she's not, there's no leukocytosis, no current infection. Electrolytes are normal. Thyroid function is also normal, okay? So suppose I can give you someone with palpitations and a history suggestive of hyperthyroidism. And if I ask you what test would you do? So one test would be thyroid function test. You want to see thyroid function test. Hmm? No, she doesn't have. This case doesn't have. But I'm saying I'm just giving you different hypothetical examples. So if there is a situation where there is a history which is suggestive of hyperthyroidism, and then with palpitations, and then if they ask like which of the following tests would you order, so then you would go with thyroid function test. If there's ECG, yes, you will do ECG. But if there is like no ECG and if there blood workup and there is a thyroid function test, so obviously the correct answer should be thyroid function test. So in hyperthyroidism, which type of abnormality do you see commonly? Like which type of ECG abnormality can you see? We'll see, we have a case, let's see. So echocardiography was normal with normal ejection fraction, yes? I'll come back to that question. We have a case. Is chest X-ray normal?
Yes.
Yeah, so it's normal. So this gives you the algorithm, like what would you do if someone presents with palpitations. So obviously after history examination ECG, if that is pointing to a definitive diagnosis, you will confirm that diagnosis and you will treat it. But if the palpitations are not explained with your initial workup, and if there's no abnormal heart disease and the ECG is normal and the palpitations are rare and the patient is not like affected by that, then you stop your workup. But if they're frequent with the normal heart and ECG and severe, or if you have any abnormality, then you will go with the further workup, which will include echo, ambulatory ECG, MRI, stress test, and EPS, which is electrophysiological studies, which electrophysiologists like Dr. Bandal Gandhi is an electrophysiologist. So they do these studies. So they go into the heart, and then they record, like we record ECG on the skin, but they record the electrical activity inside the heart, and they identify the areas which are giving problem, and then they ablate those areas. And then you can treat, or if you still you don't find, then you can implant a loop recorder which will record ECG for a longer duration. Otherwise, normally what we do, like when the ECG is normal, they have palpitations, so we give them a hold amount, like ECG recording for 24 or 48 hours. And we try to see if they are having any abnormal rhythms during that period. So they come back, they do their routine activity, that things are attached to them, and they maintain a diary what times they had symptoms, and then they come back and then they look at the rhythm and they try to correlate with the symptoms and they see if there's any abnormal rhythm. But sometimes if they are rare, then they won't show up in probably 48 hours. So, and if they are giving problems, then you might want to implant a loop recorder which is there, and whenever they have symptom, they can like press a button and that thing is recorded. Okay. So obviously I will not go into that treatment. So Valsalva maneuver and carotid sinus massage were attempted without much success. So again the question is like, what is the role of Valsalva maneuver and carotid sinus massage? Yeah, so it will increase the vagal output, so it will suppress the AV node. So because it's coming from supraventricle, so you want to reduce the conduction at the AV node. Because usually the most common mechanism of this type of arrhythmias is re-entry phenomenon, where it's underlying is sympathetic, but like in the heart it's like usually the re-entry phenomena. So they might have some accessory pathway, and there is a re-entry tachycardia. So this comes under re-entry, and so there's a re-entry. Did you do? I think you did in your lectures. Yeah. So you want to increase the parasympathetic output by these physical maneuvers, and we don't have time to go in detail. Otherwise, they used to discuss like how do they increase the vagal, like this massage increases the vagal output. And do you know what is Valsalva maneuver? Okay, good. This is. So you try to breathe out with the closed glottis. Like I don't need to close nose, I just need to close the glottis, okay? So you are increasing the intrathoracic and intra-abdominal pressure.
Doctor, what about carotid massage?
Carotid massage?
Yeah.
Yeah, so that also increases the parasympathetic output. So this is part of, so you have two things that you can do. But that did not help in this case, so we gave her IV adenosine, and which worked, and the her rhythm came back to normal. Okay, how adenosine works, that you can study, because I think you will have this in your PBL as well. It should be there. This was also one of your PBL cases, but like then it was removed many years back. So, and then she was discharged on atenolol. So again we are giving a beta blocker. Okay, adenosine again slows down the conduction in the AV node here. It reduces the automaticity, and that's how it terminates the SVT. So to terminate any SVT, supraventricular tachycardia, you can do either the vagal maneuvers, or you can these are called vagal maneuvers, like Valsalva maneuver or carotid sinus massage, or you can give IV adenosine. And then for long-term management, if it's giving problem, you can give a beta blocker. If that works, fine. That's for the acute management. Acute management. For long term, you will give beta blocker. If that did not work for acute management, you gave IV adenosine. But for long term, you gave her beta blocker. But one month later, she comes back and she's not well controlled. She's again having symptoms on the medication. So you either change the medication, or you can do further electrophysiological studies, identify any abnormal pathway, and you ablate that. Okay. And obviously, this is when to refer. So the situation and when you need to admit the patient. So when they're elderly, when they're syncope or near syncope, when they're low hematocrit, tachycardia, or also tachypnea, and things like that. So other cardiac disease, then you need to admit them. Okay, so we have 3-4 cases very quickly. Okay, so we have 23-year-old lady with palpitations in emergency department. She was treated as having supraventricular tachycardia with vagal maneuver and IV adenosine, like this case. So her rhythm, heart rate came back to normal. Now this is her ECG after that at rest. So this ECG was taken at rest after those maneuvers when her heart rate came back to normal. Okay. So she is not having tachycardia at the moment. She presented with supraventricular tachycardia, but see, this is the role of ECG. ECG, even when the patient is not, when the patient presents to you and he is not having any tachycardia at that time, but you can find some other abnormalities in the ECG which will give you clue to the underlying problem. Like suppose if you see someone who presents with an elderly person presents with palpitations, you do an ECG. At that time, there is no palpitation, no tachycardia, but you see Q waves, evidence of previous MI. So you now know, okay, this patient had previous MI, so probably it's coming from this scar. Or if you see the evidence of left ventricular enlargement, left atrial enlargement. So someone who has heart failure, left ventricular hypertrophy. So you know that can also lead to atrial fibrillation, and that can present with palpitations. Or they have atrial fibrillation. Again, you know this can lead. So there are different ECG abnormalities which may be there, and which and sometimes that can lead to tachycardia and palpitations. So like this case also has an abnormality. So can you identify that? Sorry? No. Why inferior mitral infarction? ST elevation? How? Where? Come on. Don't say this at this time. So see, this is view 3. This is AVF. AVF. This is D2. Do you see any ST elevation here? No? There are normal Q waves as well, so don't confuse the normal Q wave with the abnormal Q waves. Yes, WPW syndrome, Wolff-Parkinson-White syndrome. Good. So there, do you know WPW syndrome? I think it was done in your clinical lectures. I have seen those lectures from last year. So you see the J wave. You see the J wave here? Sorry, not the J wave, delta wave. Sorry. Delta wave. The slurring like a J is a delta wave. You see this delta wave?
I'm so shocked we are.
Like here I can see in the V1, it's very obvious, and V2 as well. And so also like here I can see the slurring. So the apparently PR interval is reduced because of the early depolarization. So you see the slurring of the R. So this is very obvious. So this delta wave is indicative of WPW syndrome. So and they tend to develop tachycardia, supraventricular tachycardia. No. That I don't know. but what I know, there has to be delta wave because of the early start of the R wave. So PR interval appears small, not that wide, but like because of the early, yeah, so it may appear wide, but it's not wide like in the ventricular tachycardia. It's not more than 120 milliseconds. That's what I remember. But you can read the criteria for WPW syndrome, but this is WPW. So here, if I ask you the diagnosis, it would be, yeah, so D, WPW syndrome. Obviously, it's not PE, it's not bundle branch blocks, or not pericarditis. So, okay, in this case,
C, generalized. Sorry, D, panic.
yeah, D, panic attack. So this is typical of panic attack. So they have all the symptoms of like palpitations, and they may have this constriction in the chest, so which might be in MI or SES, but they have this feeling of impending doom, like the world is going to end, I'm going to die, and then this goes away in few minutes. So and they become all right. So this is typical of panic attacks or panic disorder. And they might have breathing problems and all those things. So, okay.
Doctor,
Yes,
how can I make sure it's panic?
Edson.
How can I make sure that's panic disorder, not other causes?
One thing, the history is obvious, but again, even someone comes with typical history, you will do the ECG, you will do other like metabolic workup and things like that. You will do those. But in this scenario, the most likely thing was it's not phobia, it's not personality disorder, it's panic attack. Okay? I have only 1 minute left, I have to go for the other classes. So this 32-year-old lady with weight loss, increased appetite, palpitations and diarrhea. Hyperthyroidism, huh? And you want to check the thyroid function test. But the question is, what is the most likely cause of palpitations? Yeah, so these patients have atrial fibrillation as an abnormality. They can also have ventricular ectopic beats. So A can also be an answer. Okay? They have ectopic beats. The ectopic, again, ectopic beats can happen with sympathetic stimulation, and this is what thyroxine does. Sorry? Why is? Atrial fibrillation. Yeah, that also happens with the hyperthyroidism. But this is not; these are not the most common abnormalities, are not the most common cause of palpitation and hyperthyroidism. The most common is sinus tachycardia. So the most common problem or most common abnormality that you will see is sinus tachycardia, even with hyperthyroidism. That can also lead to palpitations, but they can also have atrial fibrillation. They develop atrial fibrillation. Why? That's a separate discussion. I don't have time for that. But because it's just, sorry. That's why I'm having discussion with you. So here there can be possible 2 answers at least. Like he can have ventricular ectopic, so he can have atrial fibrillation. If it is exam, then obviously I will show you an ECG. So I hope you can identify ventricular ectopics, you can identify fibrillation. Okay? Or if it's sinus tachycardia, you should be able to identify that. Huh? So obviously in that, see, we don't want to trick you or fail you. This, we keep little information so that there can be discussion. Okay, what is this? 45-year-old female presents with palpitations. She has hypertension, anxiety, asthma. Ventricular? It's not tachycardia. Huh? There's a ventricular thing, yes. It's not fibrillation. Then she would collapse. So no, it's not supra, it's a ventricular problem. You can see, can you see these complexes?
Yes.
Huh? So they are coming from, yes, premature ventricular contractions. PVCs. So, and what happens in this situation, because when there is premature contraction, so patient doesn't feel that. Sometimes patient don't feel anything, but sometimes what happens, after the premature contraction, there is, so obviously there will be no P wave before this premature contraction. So you will see a ventricular complex without a P wave, and then there will be a pause. So what happens with the pause? Patient will feel the heart has stopped, and there will be more filling during, because it's a longer duration. So there will be more filling. So the next beat which comes in, there will be more stroke volume, and that's where they will feel the heart restarting. So flip-flopping feeling. So heart has stopped and they restarted, and that gives them the feeling of palpitation as well. Okay? These things I have already sent to you, so I won't go into. So this flip-flopping, I've just explained, fluttering, pounding in the neck, circumstance. So this is another example where there was an arrhythmic problem. There was abnormal tract which was ablated, but initially for 6 years she was diagnosed as anxiety or some panic problem. Yeah, a panic disorder. And 6 years later they found this arrhythmia and they treated her. Okay. So we discussed most of these things. So again, on examination you can find some evidence which might point to certain underlying etiology. These things I just discussed with you, like WPW and like Q waves for the previous MI or something. Okay. Okay, one thing remember, probably we might prepone our next session on murmurs. It may be on Sunday or Monday, okay? We'll probably prepone because